everybody. So I prepared this presentation is not meant to go over every detail, but I wanted to be a resource for you. Education is key. I sometimes I think my patients are there. She goes and hear physiology rant because I like that side effects is because of this and this. But so I hope to answer some of your questions. I got them ahead of time and I included in the presentation. Also at the end, stop me, ask questions. This is a conversation. This is not me regurgitating another graph and another data. I really wanted to bring what really will focus in our young patients. So mostly targeted therapy, new therapies, new drugs. What is out there that will give us hope? And that my patients, my young patients, always are like, "What is next? What can I do next?" So I wanted to do that. All right, let me share my screen. I have like 3 screens, so let me know if you see the full presentation or you are seeing the presenter's view. Which one are you seeing?
We're seeing the presentation now.
Okay, sweet. So I don't know what I did this morning, but I made this presentation like it's a concert. So it's the ASCO 2024 concert with young long lenses. Yeah, I like Journey. So we have a today's set list is new drugs updates. Then we're gonna have the opener of the middle stage, which is the crown data, ALK. And then we'll have the main stage of the headliners, which is the virtual palliative care data and LARA trial, which is for stage 3 unresectable EGFR. So I hope to make it a little more fun than just, data and data. So don't stop believing. Here we go. I don't like new music. So let's talk about the new kids on the block. And I focused on the new kids on the block and things that I believe, based on the data, are going to move forward. We need to be very careful because there's always a new compound that's very promising in phase 1. So phase 1 is when you're evaluating for safety. They go by different levels. It's called a 3+3 design. And it's hard to make that a drug is going to move forward with only 9 patients. So I focus on some of the phase 2 or phase 1 that have very, very good data. So this one was presented by John Hamek for Andy Anderson. And this drug is called, I need to learn how to pronounce the new drugs because I knew the name. So all the drugs, before they get a name, they have a letter and numbers, right? So the former name of this drug was BI 1810631, right? It sounds like, why do we, but that's what they do. But the new name is songertinib. Songertinib? And it's a new HER2 tyrosine kinase inhibitors. It's developed for HER2, but it is important to understand that the second mechanism of resistance in patients with EGFR after MET amplification is HER2. And the only HER2 therapy that sorry, that's my nurse practitioner. The only HER2 we have approved right now is an infusion that I believe could be very toxic with Tagrisso. So this agent, I think it has potential because will inhibit HER2 and also has low mediated side effects with EGFR. When you have a resistant mechanism, you have to target the initial clone, the EGFR that give the cancer, and the resistant mechanism. That's what I brought this kid to talk about. And I know one of the questions was what happens after Tagrisso. This is something I think is very promising. The drug wasn't that toxic, but of course, I'm not one to say who toxic is. I'm not getting the drug. Patient's voice is what matters, like Jill, we always say. And also have very low rate of EGFR mediated side effects. What this means is you won't have super mega side effects or EGFR side effects if you have the Tagrisso. It has very good preliminary activity. They are going to move to the next phase of development in patients harboring HER2. And I just wanted to bring, that's the first artist. You know, when you're in a concert, the first person in the concert, you're like, hey, sure, let's see how it goes in a few years. So this is the first artist in this concert. Some girls in it. There's future there. The other one, I know people have questions about ROS1, right? A lot of people put questions about ROS1, and ROS1 is very common in individuals. And we had this new drug called taletrectinib. And we have 2 drugs for ROS1. Before it was crizotinib. And then we have entrectinib and repotrectinib. And now we had this new drug. It's a phase 2, so it's more advanced than the other one, and it's called taletrectinib. For the ROS one, the people that ask about this question, why do we need new agents? We always need new agents. Because if we wouldn't have developed new agents, everybody would be enerlotinib or Tarceva and having 12 bowel movements per day. When I was a resident, we used to put patients in the hospital because of Tarceva. So we knew new agents, we knew new mechanisms of resistance to by the new mechanisms of resistance. So this new one, ROS inhibitor, is very promising because it treats CNS disease or in the brain, which is very common for ROS1, and it can overcome some of the acquired resistance to the other agents. So it's a next generation drug, and has less side effects in the CNS because repotrectinib, which is the best drug so far, gets to the brain, but it makes people very dizzy. And it has neuropathy, and people can get confused. So while this drug gets to the brain, it has less side effects. I think there is future there. Any thoughts about the people that ask the questions about ROS1 or what is next? Questions, concerns, issues? You can interrupt me on, all right. Or you can put messages anonymous in the chat directly to me, and I won't say who say anything. So these compared to crizotinib, the trial compared to crizotinib, it was 173 patients, largely Asian patients. Always need to take that into account because we metabolize drugs compared to our Asian friends. But it was compared to crizotinib, which is no longer a standard of care. And it has been the same thing with a lot of ALK data. But I think taletrectinib or TROS1 has its future because it's better tolerated. And they have patients that were pre-treated, that they have crizotinib before. You know, repotrectinib was just approved last year, so still new. So the patients that didn't have treatment before, they haven't reached a median time for progression-free survival. That's what I think this is very exciting. So what this means is that at 24 months, they didn't have 50% of the patients that the cancer has grown. That's what I think is very promising. At 24 months, 70% of the patients still were responded. And that's why they couldn't find a median. So I think it's very exciting. The benefit wasn't as good with crizotinib, but we don't do crizotinib anymore. But I think it's very exciting for ROS1. This may be the next kid in the block. We have no reach median at 24 months. If I can keep my patient in the same drug for 24 months, there's a lot of things that can happen to that. So
I do have a question real quick.
yeah.
So when and if this drug were to get approved, would this be like a second line of a treatment? And then are there statistics on how effective it is, I guess, as a second line? Because I think from what I've learned from my oncologist that like second, third, fourth line of treatments, the percentages of responding to it are lower, but I could totally be wrong.
That's correct. So when the clone has been exposed to an agent, the clone is most likely to be resistant. The clone is the gene that produced the cancer. None of you deserve this disease, or one of your family members. It was the stupid gene that caused this. And the more you expose the clone, the more the clone will learn how to grow. But this is a new generation and is overcoming some of the resistant mechanisms. Because that's how Tagrisso was developed, to overcome T790M. And now it's the first line. So I think taletrectinib will be moved probably to second line. And if it's better tolerated than repotrectinib, eventually can move to first line. But that's years away. But that's correct, Ashley. The more the cancer gets exposed, the more resistant mechanisms we have. But I'm excited because I have patients on repotrectinib, and it makes people very dizzy. And when you're dizzy, you just fall and you're worried about having a life and leaving your house. So go ahead. So the neurologic side effects were low here, were mostly grade 1, and I put this arrow here. because neurologic side effects are very hard. Like my mom has visual changes, and that affects her. So people that don't know, my mom has the disease, and that affects her life every day. I just called her before this call, and she was joking. She's like, I think he was handsome, but my cancer eye didn't let me know. Because so she's single. And I think it was a joke, but it tends to affect everybody. But 40% of patients didn't require a dose interaction. So it is not a walk in the park either, but it may be better tolerated than the other ones. Okay. So the next one is for exon 20. And I think some people were talking about exon 20 in the call before I joined. And I've been waiting for this guy, subcutaneous, longer than a lot of kids have been waiting for Santa Claus. And this is amivantamab. Amivantamab is the first line treatment for EGFR exon 20. Sorry, I need to find out what's going on with my nurse practitioner. Oh, shoot. Okay. So amivantamab is already approved for EGFR exon 20, and it may be approved for classical EGFR after Tagrisso, because that's the Mariposa trial. But the problem with amivantamab is that it produces reactions to the infusions. 89% of patients, we have a reaction with day one. It gets better over time. But it's very hard for patients. It also has significant skin toxicity. I had a patient yesterday. We are like, we're gonna take a break. This skin is too much, and she wants to take a break, and that's fair. But this is subcutaneous. It means like insulin or like Lovenox or just shot, not an infusion. And they were comparing it to see if it's as effective as the intravenous way. Also, the intravenous way is 2 days in a row, then weekly, then bi-weekly. It is very time consuming. And also increases the chances of clots, the combination. So the Paloma 3 trial that my friend presented is subcutaneous. And they were comparing it with the standard of care amivantamab for exon 20. And this is not going to only benefit exon 20, also is going to benefit patients with classical mutations, because eventually Mariposa is going to get approved, Mariposa 2 as an option. So the subcutaneous version was similar to the IV version, and you may argue that may be superior. And I think it may be superior not because the drug is better, it's because patients can tolerate it better compared to just turning red like a tomato. A few months ago, one of my patients, I adore my ladies. She had a reaction and the nurse called me, and I heard my patient in the back telling the nurse, it's okay. This is expected. 89% of patients are gonna have a reaction on day one. And I was like, that's why educated patients are so great. Yeah, she was calming down the nurse. So the point is that it was similar and maybe have lower rates of clots. All right, let me look at the chat quickly to make sure we're not missing. All right, there's some very good questions then. I have become an expert at saying this one because I'm here too, right? Thank you. I need to learn for you about that one. Is there a pattern? Okay, there's very good questions there. So I'm gonna go to that at the end. I may skip it some of this presentation because the questions are so good. Another agent that I think wanted to mention also in exon 20 is sunvozertinib, or the WUCON-1 study, which is for patients with exon 20 insertion, something else we were talking early. And the WUCON-1 study showed that this compound had a good response of 45%, and it lasted for 9 months for around 57% of patients. So this study is already moving to phase 3. So this will be a new agent for exon 20. It's mostly being developed in Asia. So hopefully that doesn't delay the development of that in the US, because when the trials are only done in the US, the FDA is like, hey, in Asia, the FDA is like, oh, we need patients that represent the US. Okay. So I want to talk about the next one, because we just talked about the next generation ROS1, and that's what lorlatinib is what we're trying to look for ROS1. Lorlatinib is for ALK positive. ALK is the top mutation in younger patients, followed by KRAS G12D, D as in David, and EGFR. So ALK positive lung cancer has a very high risk of going to the brain. These cells like to go to the brain. I have an 18-year-old, a 21-year-old, and a 25-year-old with ALK positive lung cancer. I hate ALK. I hate all cancers, all lung cancers, but ALK is one that like. So this study, 5 years survival compares lorlatinib to crizotinib, but I want to show everybody here this graph. And what this graph means, this graph means that we had developed a drug that after 60 months of follow-up, 60% of patients were still on the drug. This is 5 years. I have patients that have been able to have babies in this drug. Like we take a break from the drug, but they have been able to have babies. And this is what I hope, I'm showing this because this is what I hope taletrectinib with the new EGFR inhibitor will be. Because at 60 months, 60% of patients were still in this drug. This drug has very unique side effects. I don't have to undermine that. It is a challenging drug, but it gets to the brain in a beautiful way. This compares with crizotinib again. You know, you're comparing a Tesla to a Corolla. You know, we all like our Corolla. How many of you have a Corolla or a Camry when we were in college? I had a Camry 1995 when I was in med school. But it never broke down on me.
Yeah.
That Camry 1995 never broke down on me.
Mm.
That's crizotinib. It gets you to places, but it's not the best one. So lorlatinib is the Tesla, not the Tesla truck, just a car, and it gets to the brain. And this is what I want to show you guys here and ladies. How is superior when it comes to the brain penetrance for a disease that before lorlatinib we really
There,
struggled.
you want to pick your piece?
And I want to show you this graph. This is the amount of patients that have progression in the brain on lorlatinib, which is 8% of patients only in 5 years. And I'm reading this because this is helpful to me. In 8 years, in 5 years, only 8% of those patients have progression in the brain. When before, it used to be the opposite, which was 79% of patients, the cancer would grow in the brain. So but everything comes with a price. Lorlatinib gets to the brain, and because it gets to the brain, it has these very unique side effects. It affects the mood. People can get forgetful. It can produce neuropathy. But one thing that happens to most patients is your cholesterol will shoot up. So I start all my patients on cholesterol medication day one. Why? To fix a problem when I can prevent it. I also keep them very close to me because that is a pill doesn't mean that, you know, they have to go home. Like my patients say, your high functioning anxiety is very good for patient care. She told me that 2 weeks ago. But it is a very good drug. But something to mention too is that dose reduction is possible with this drug without affecting the outcomes. So patients that went to the 75 milligram dose instead of the 100 dose did not notice a difference in the outcome. So dose reduction is possible. It can be discussed. It can be done. It did not impact efficacy in 16 weeks. And that's very important to talk about drugs. I don't think lung cancer treatment is a continuous thing, it's an evolving thing based on the needs. One of my patients just got married 3 weeks ago, and we prepped for that. Everybody prepped for that wedding. The nurses, everybody, we were prepped. We actually give him one of the bone marrow transplant trays as a celebration. We prep and we modify the treatment to that very important life event. He's marrying the love of his life. So then we adapted to that. I have a patient that really, really wants to go to China and she's leaving next week. So we prep for that too, because our patient's life need to be adjusted, don't need to be adjusted to treatment. The treatment needs to be adjusted to their needs. All right, I'm almost coming to the end so we can do questions. But the main stage here is the virtual palliative care. I was part of this study and the LARA trial. The virtual palliative care, I brought it in because it's very important. it allows people to get palliative care wherever they are. When I was at the Mayo Clinic, before I was at Dana-Farber, I used to have patients in North Dakota, South Dakota, Iowa, Montana. We're very privileged in Boston. In some parts of North Dakota, there is no a palliative care doctor for 100 to 200 miles. It's very hard to find that. It's very hard to find even an oncologist. So this study evaluated virtual versus in-person palliative care for patients with lung cancer. And these patients needed to have metastatic disease or incurable disease, and they were randomized all lung cancer, all lung cancer. And this is the first time there's a plenary session. The plenary is like the headliner, like Coachella. Like you all remember when Beyonce changed the history of Coachella? Well, this is what the plenaries are at ASCO. So they divided patients to virtual visits or in-person visits, and they followed them through. There were patients with non-small cell lung cancer that didn't have an outpatient doctor for palliative care, and they had advanced or metastatic disease. Unfortunately, only English or Spanish speakers were allowed. Hopefully, they can be expanded. Included, the majority of the patients are on this older side, majority women, but they had a good representation of other groups. Usually, we see these numbers to be 0, so 9 to 12% of patients were Black. Hispanics is a 5%, I wish more, but let me not complain. But this intervention of virtual palliative care was no inferior to the in-person visit. And this is very important for young patients because you have childcare responsibilities. You have a job that you have, I don't have to tell you the obstacles, a job that you have to keep in order to have your insurance. Coming to Boston is very, very struggling. That's what I'm licensed in all New England, Wisconsin, Minnesota, California, and Florida to do virtual visits. So it was similar to in-person, very similar outcomes, very similar. So the caregivers come in. Caregivers were most likely to come in person than virtually, maybe because people need more help getting to the cancer center. But there were no differences in quality of life. There was no difference in any of the outcomes that palliative care brings. So virtual palliative care is similar to in-person palliative care. And that actually will really help payers pay for this. All right, last thing before questions is Lara. Lara is, the problem is with EGFR, we know immunotherapy doesn't work. It doesn't work. We have studied in many, many ways. There's a small subgroup of patients that my colleague Dr. Roto is trying to study of patients with EGFR that will respond to immunotherapy, but it's very small. So patients used to get chemoradiation, then immunotherapy, and then we learned that the patients with EGFR mutation shouldn't get the immunotherapy because there was no benefit, only toxicity. So the LARA trial, done by Ramalingen and discussed by my mentor, Dr. Sequez, the patients got chemoradiation, and instead of getting Durva, which is immunotherapy, they go into Agriso. The problem I have is that it's indefinite. It's indefinite Agriso, no end on site. But this is the difference of the cancer coming back. This is the big difference. At 24 months, the patients that were in Tagrisso, 65 of them didn't have the cancer coming back compared to 13%. And the difference was 39 months versus 6 months. That's a 33-month benefit of adding this medication. I have to say I already was doing that, wink. But now I had the validation for it. And it wasn't a standing ovation because before this, patients with EGFR had up to 75% chances of the cancer coming back in the first 2 years after chemoradiation. So that's more options for my ladies and men. I see a few men. And overall survival, this means do you live longer or not with this? Still pending, but most times potentially to be positive. No new side effects were found. All right, I'm gonna stop. We will send you the slides. But I wanted to bring these set reviews. Let's review the set of the concert. Endless osimertinib, something to take into account. Financial toxicity, the drug is expensive. Can patients have dose reduction? Can they go to 40 milligrams? Can they go to 80-40 as a possibility? could we just do 5 years and watch the patients, or does it really need to be endless? These are some of the questions I have. In compliance, how can we help our patients stay on the drugs? But most important, how we can help them pay for these freaking drugs that are so expensive. And as younger patients are affected, what are the long-term side effects of endless osimertinib? We know it can produce irritable bowel syndrome, can produce cavities, hair, sexual, financial, skin, eyes. So what are the long-term side effects and how can we help with that? Because it's not only CT scans. Fertility, always fertility. If you're in my clinic, you can be 49 and have 7 kids. I'm gonna ask you if you wanna preserve your fertility. I have a patient that told me, it's like, if I have another kid, Dr. Florez, I'm gonna turn crazy. No, I don't wanna preserve my fertility, but it is my role to give you the option. I had a patient that the youngest patient son is 38. She had kids very young. And she's like, can you imagine me having a kid? I cannot imagine, but I want to know if you want to preserve your fertility before we start treatment. Treatment options. What happened after progression? We need new drugs. And also, how do we watch the CNS? All right. So I'm going to go with the questions and then we make a conversation. Sounds good? We're going to send these slides to everybody. The first question is, was there anything at ASCO about next treatment for EGFR? So the one update was the Mariposa 2 trial. We know about Mariposa already. Mariposa combines amivantamab with lazertinib. So it's a pill and an infusion. The problem with the combination is that it's toxic. It produces clots, significant skin toxicity, but we learned that some patients will benefit from this combination. So we expect that Mariposa may get a Mariposa 2. That's when it's second line, may get approved in the next few months as therapy after osimertinib. Also, we have data on Dato. Dato is an antibody drug conjugate, which is a chemotherapy dressed up in Gucci. That's how I call antibody drug conjugates. It's this drug that attaches to the cell and delivers the chemo inside the cell. So the data for Dato showed that patients that have actionable mutations like EGFR and ALK may be the group that benefit the most from Dato. So there was updates on Dato. So for after EGFR, we have Mariposa 2, we have Dato as a potential next line treatment. There was some other negative trial with other antibody drug conjugates that didn't play out. So I think that what is new in the subcutaneous amivantamab. Questions about what is next with EGFR? We also have Black Diamond, who is upcoming and is evaluating for resistant mechanisms and rare EGFR mutations, outside of the classical. Leah, any questions here? I'm putting you on the spot.
Me, I think you've hit a lot of them. I mean, we have some more that have come through, and Caroline definitely has those. But one that, as a common theme, and this is just kind of advice maybe, is what do you, in your opinion, what do you think is the best way to approach or ask your current oncologist for a referral, for a second opinion? Because so many people's insurance require that, and some oncologists are open to people getting second opinions and some are not as favorable. So what would be your best advice to those patients trying to get a referral or wanting a referral?
I have to tell you my own, I'm going to talk as not as a doctor, but as a patient. I have a very rare condition called thoracic outlet syndrome. So I had chest tubes, lung surgeries. My first doctor was extremely patronizing. He used to call me sweetheart the whole time. And I was already a doctor in faculty. And I told him, don't call me sweetheart anymore. And then I say, I'm going to get a second opinion. And then he was a surgeon and he got all intimidated. And I was like, this is my proof that I need a second opinion. That you don't like the idea of getting more people here to help me. And then I found a second opinion, and then I went with my second opinion for my 3 surgeries. I talk as a patient. You're only one, and the oncology doesn't feel comfortable. Then that's not a reflection of you; it's a reflection of them. Today, I talked to 2 doctors that saw my patient as a second and third opinion. So we all can coordinate. I actually created a group text because I don't know everything. There is nobody that knows everything. Even my boss that discovered the gene and developed osimertinib. No. So it doesn't work. You sometimes can you also can get a referral for your primary for a second opinion. I have some young women that have come to my clinic with a referral from their primary care doctor. So
Thank you
you
for
don't need an oncologist.
Okay, thank you for that answer. I would also like to ask you, what is your biggest piece of advice for those of us that are diagnosed as young lung cancer patients? What is your advice on, what steps we should take to prolong the efficacy of our TKIs? Are there things you think that help people stay on that first line of treatment longer in general?
I think one of the things that is understandable is that lung cancer fluctuates. It is affected by our immune system, is affected by our microbiome, which is the bacteria and the flora you have in your gut, is affected by a lot of things. So when I see a patient have progression, the patient doesn't have progression, the cancer progresses. Sorry about that. When the cancer progresses, I put a needle in it. I think it's very good to be certain, at least as far from cancer growing that you see it everywhere. It's very important to do a biopsy to confirm progression and confirm the resistant mechanism to do. To last alone, there are many things. Flora2 is one of the data that shows them Florez when we add the chemo to make it last longer, but we don't know if people live longer. We know they last longer, but we don't know if people live longer yet. So combination strategies is something that can make you stay on the therapy longer. But we don't know if you're going to live longer if you do it together or sequential, right? There is no diet. I actually going to present that at a work conference because Dr. Jorge Nieva and I had this large study. It's a 12-year study called the Epidemiology of Young Lung. So you may be part of it. As we go to an alchemy, we didn't find a difference in diet. And the groups of the 230 patients. So diet, that's a very common question. We do know that cortisol increases cancer progression in animals. Okay, so cortisol is a stress hormone. Animals only, but cortisol is a stress hormone. Our body, or patients are mind and body. Everybody's mind and body. When you're stressed out, you get back pain. When I was giving my talk at the United Nations, I given hundreds of talks. I was so nervous that I couldn't go on the podium because I was having diarrhea. I was stuck in the bathroom. And that's what is the perfect example of our mind and our body, right? I was so anxious that I had full-blown diarrhea, like I had a parasite infection. And people's like, and welcome, Dr. Florez. And I was like, oh my God, here we go. And I'm walking there with cramps. So your mind affects your cancer. In animal models, when your high levels of cortisol has been associated with tumor growth. So it may sound like it is not a drug, but it works as a drug. Meditation, cardiovascular exercise, connection is very important for patients. Connection with your family, connection with your friend, connection with other patients is a very good source to lower the anxiety. And it is understandable you're going to have anxiety. It is no you're choosing. You just got diagnosed with this stupid disease. So what I can tell you is that connection, community, diet, and exercise can help you stay in your therapy longer because it lowers the cortisol levels.
Thank you. That's great.
Yeah.
When talking about young lung cancer and those of us that are diagnosed under 50, obviously are at a different spot in terms of like many of us are still working, many are still raising children. We have different needs. And a lot of times when I say to people or mention seeing a palliative care doctor, like you just spoke about, people think palliative care means you're dying and that's why you're going to palliative care. Can you clarify some of the things palliative care can help you with, like help the patient with, especially a young lung cancer patient? Because I know when I was first diagnosed and somebody suggested palliative care, and I was like, I am not doing that. Like, I'm not putting one foot in the grave. So could you kind of debunk that and explain kind of what a palliative care person or doctor does for the patient?
So I think the word palliative care has been associated with hospice. Hospice is end of life care. But palliative care means symptoms management and symptoms control and emotional support. I refer most of my patients to palliative care, regardless of symptoms. I don't bring it up the first visit. Sometimes I do if they have a lot of symptoms, but if I bring it up later on if the patient is interested, because you will live longer, period. We're talking about drugs right now, but there's a study from 2011, and I don't know how many of you still have the phone that you had in 2011. We don't, right? That study from 2011 showed you can live up to 6 to 9 months longer if you get referred to palliative care early with lung cancer. So we talk about this data, right? These new fancy drugs that may control the disease for 5 months. When we have an intervention, the patients will live longer and their quality of life can be twice as good because these doctors focus on symptoms. And this healthcare system that's broken, despite me, I try not to run long in clinic, but it's hard to have scans, side effects, financial toxicity. How, and in Boston, there's always a teen playing. There's always a small talk about the Sox, the Bruins, there's always that. So having another set of ears and a person that specializes in symptoms is very important, particularly with complementary and alternative medicine. I'm a big fan of complementary and alternative medicine, but I don't know it all. So having another set of ears really helps. And it's not only about pain, because the people think it's only pain. No, depression, anxiety, nausea, diarrhea, skin changes, all of this. May palliative care be called? No, we cannot call it integrated medicine, Phillips. It's integrates things that are also no therapeutic, like yoga and Reiki and meditation. So that palliative care doesn't do that. But it is not end of life, and people live longer and live better. If there is a pill that added to one of the questions was, do you think there's any benefit of targeting more than one mutation? I think there's greater benefit on having palliative care early on. And if you don't need it, use it then as needed. But it's always good. And my patients have a very good relationship with our palliative care doctors. Not all of them, but yeah.
I would agree.
And
I'm glad I sought that out for sure.
I just wanted to jump in and say that actually Young Lung Cancer Initiative is having another webinar in September with Dr. Laura Petrillo from MGH, who's a palliative care doctor.
I adore that woman. I adore her. We have run papers together and we just plan an entire track for work conference. She's excellent.
I guess another question, and if there's people in the audience that would like to ask questions, please feel free. I'm just going on with some questions that were asked in the Young Lung Cancer Facebook group. But in regards to the young lung cancer patient, I found great benefit in connecting with other patients that are young, even if it's not the same mutation. Do you have any advice to patients on how to make connections, and sometimes more, I know online a lot of times, but more locally? Are there places you recommend? And I know you're in Boston and I'm in Kentucky and we're all over the place, but is there a particular way you think is best to connect with others?
There are several things. One, take into account not everybody's in social media. Like my mom is only on Facebook, right, for example, and not everybody's on social media. Social media is a good way to connect. The cancer, Bianca started the initiative, is a good place. Another place are focus groups. At Dana-Farber, we have now a year, we have focus group for young patients. And anybody can join. You don't have to be a Dana-Farber patient. And they're virtual focus group. If you're interested, I can send the link. You can join that focus group. It's run by Mariah. Mariah is a cancer survivor herself, and she's a licensed master social worker. So I work with her. She's an angel. She's these people that you talk to and you're like, oh, like just talking to you. I probably have dopamine, serotonin, and everything. So young patients can join that focus group. I'm gonna send it to you so you can send it to everybody.
Thank you.
You have to register because unfortunately we had it open and some people joined and there were bots. But that is a way to do it. Focus group. This focus group is at Dana-Farber. but anybody can join. You don't have to be a Dana-Farber patient. Another way to connect is ask your doctor. So I have a patient, and I asked for his permission, that has a very rare type of lung cancer. We talk about ALK being rare, RET being rare. This is 0.1% of lung cancers. 0.1%. And I was like, okay. And then we started in this journey. And then I had another patient with the same type of lung cancer, mostly because I focus on young patients. And I was like, can I connect the two of you? Go behold, they spent 4th of July together. One had a barbecue and the other one drove an hour, and the wives get along. And so as your doctor, I also have patients that are pregnant with lung cancer, and I connect them with each other. Because that's just how many people you're gonna know. So your oncologist can be a very good source. And I have a group of all abuelitas that also met in my waiting room. It's 3 of them. They're Hispanic grandmas with EGFR, and now they're besties. They go to church together on Sundays. They don't speak any English. So there's all those resources, and I will send the link to the focus group, to the support group, no focus group, support group.
Thank you. I think that Steve may have a question. He's got his hand up.
Yes, thanks, Leah. Dr. Flores, I asked 2 questions in the chat,
Okay, sorry.
but if it's okay, I'll just raise them now and you can just, okay. I asked whether there was anything new, because I've read papers in the past, but nothing beyond papers I've read a paper from Revolution Medicines, for example,
That's exactly
regarding KRAS G13C, not 12C, but 13C.
yeah.
So I wondered if there's anything new regarding that. The other thing that I asked, if there's anything new on chemo. I know about immunotherapy, but chemo for non-small cell lung cancer brain metastasis.
So the paper that you read is there's 2 things for KRAS G12C. I also have a
No,
few patients.
13C.
13C, sorry, 13C. I have a few patients. I actually, the first time I had a patient like that, I emailed my molecular pathology and say, "Do you made a typo?" And they're like, "No, it's 13C." So the revolutionary medicine pan-KRAS inhibitor is the drug that's more promising and move it ahead. I think that would be. But there is a new study from Astellas too, that is a antibody conjugate. That's a KRAS pan inhibitor. So none of these inhibitors, Steve, are specific to the G13C, but they're pan inhibitors. So the revolutionary medicine RNC 68, all of those
36.
numbers.
6836. Yeah.
That's the most promising, but revolutionary medicine is developing another pan inhibitor that the study is open now. And the Stella study.
How do you say Stella?
I will put it in the chat. There's the company.
Okay.
Yeah, let me see if I can pull this study and I can put the whole name on it. Oh, sorry, I sent it to the wrong person. Sorry, Lorena. Stella. Yeah, there is a study there. I can try to pull it up.
Oh, Astellas.
Yeah, that's the company. That's how it's stuck in my head. Because I'm trying to get a patient with KRAS 13 there.
Astellas. That's almost like tell us something.
Yeah, it's a company. It's the name of the company. But let
Yeah,
me
I
just
understand.
pull it up very quick. So
That's on just general KRAS mutations that they're doing something, you said, I think.
Yeah, it's a PAM inhibitor. PAM
Yeah.
means all the KRAS.
Yeah.
But the revolutionary medicine agent, I think, is the most promising. I do believe there is also another drug that's under development, but it's not open yet. I was in the phase 1 meeting early today for NCI. There's a lot of things happening in KRAS, Steve.
Yeah.
So whatever happens, it's very important that you look at very large KRAS centers.
Yeah, it's the only mutation that I have, which has been proven again and again in genetic studies. So
yeah. So.
And the other question was whether there's anything new. I know about immunotherapy, of course, but anything new? I've heard talk about
Sorry
carboplatin
to
and
interrupt.
Avastin, but wonder if there's anything new regarding
Sorry
that.
to interrupt, Steve. Steve, there's also the Black Diamond study. I'm gonna put the name of the drug here. This
Oh,
study just opened, and Black Diamond is actually based out of Boston. And
okay.
Black Diamond is the one developing the new drugs in EGFR and in KRAS. I met
Oh,
with the CMO in a plane back from ASCO, and I had the opportunity to like interrogate him. Poor guy had 2 hours of me asking him questions. He eventually, I think, pretend to be asleep. But this Black Diamond is the name of the company, and there is this agent is being developed for non-traditional KRAS mutations.
oh, thank you.
There you go.
And since
Dr.
you brought
Florez,
up Black Diamond, is there anything that you have heard about the EGFR Black Diamond? I don't know if you have any patients
So
in it or.
we just opened it here. We didn't have it open, but we are open for the drug expansion at this point. It's open to recruitment right now here. I did send one of my patients to New York City to get her into a young patient to Black Diamond in New York because it was open before here. She's doing okay. I know license in New York, so I can do telemedicine with her. She was already in upstate New York, so I actually was the reach. And she's doing okay. She sends me text messages here and there.
Oh, can I ask what hospital you're associated with? I'm in New York City. Where are you?
Oh no, she went to see Elaine, yeah.
Oh, but where are you located is what I'm asking.
Oh, and in Dana-Farber.
Oh, in Boston, yeah. Okay. So my other question had to do with brain mets and whether there's anything new that you're aware of in terms of chemo or.
No, I think the chemo development has significantly slowed down for the last 20 years. I haven't seen any new chemo drug. I think because now we treat patients based on the molecular profile. I don't, not to my knowledge.
Oh,
But there is
I'm
a
sure
doctor
you,
that you need to pay attention to. She's a new faculty, but she's a year in faculty now at Duke, Dr. Laura Alder. She's focusing on understanding brain metastasis.
Dr.
Very, very,
Laura.
very good. Alder. She's new, but that's her research. I think she's gonna
Dr.
change things
Florez,
with brain metastasis.
I don't want to interrupt you or his conversation, but we are down to the wire of 5 minutes.
Okay,
So,
I can do
Oh,
10 more minutes, but I don't want to hold people because we
thank
have
you.
but
a few
Thank you
questions.
very much, Dr. Flores.
Sorry, Leah.
I know it's so hard, but we have one question I think that would be a good question for a lot of people, just because it's been on
Yeah.
the radar for everyone, and that's some facilities, oncology centers are offering patients consolidated care, doing, see how well you respond to your TKI, and then either do surgery or do radiation therapy and then continue on your TKI. And that's what I did in my case. A year into my treatment on Tagresso, we opted to radiate my primary tumor. And now I've been on Tagresso with no progression for 4.5 years. So can you speak to that, whether you think that's something that we'll be seeing more of, or kind of just your opinion on that?
Yes, sí, we, sim, in all the languages. Yes, go to consolidation. So let's talk. I'm going to go in a physiology round. Everybody prepare. This is what I do in clinic. You have the clone. And the clone, particularly the primary tumor, is being exposed to the inhibitor, right? You keep hammering it with the inhibitor. Eventually, the clone is going to get so bothered by that it's going to develop a resistant mechanism, right? That's what happens, particularly the primary tumor. So the first study was the CINDA study. Well, the first study was Daniel Gomez and Andy Anderson, that showed the benefit, overall survival benefit. You live longer, but you have to have systemic control. The disease needs to be under control for this to work. That's the first thing. The disease needs to be under control. When you had the disease, Leah, like you did it for a year, control. I'm a big fan of this. I call this the dandelion approach. I have many names for it. So after you have control, if you treat it, the CINDA study, Gomez, and another study that was presented at ASCO. Now we have 3 different studies showing benefit of this approach, large studies. The CINDAS was only for EGFR. The study presented at ASCO included ALK. You treat the remaining disease, the clone will be less exposed to the gene and decreases the chances. Doesn't mean you're not going to develop resistance, but it prolongs the time for that to happen. And we know people can live longer, 9 to 12 months. So I'm a big fan of consolidated radiation. Last Thursday, one of my young patients, I do PET scan. So they had disease control for a year, year and a half, and then I do a PET scan to see what disease is active. Because I also not gonna go and radiate random scenes, I think, in the PET and the CT scan. But we radiate whatever is active in the PET scan. And then we do radiation. That consolidates the disease. You also can do surgery. Radiation techniques have evolved a lot in the last years, so pinpoint radiation is possible. And I want to tell you that is very beneficial mentally and physically for patients. You know that as well. And we know that the primary site of disease tend to be the more resistant site sometimes. And it's also very helpful also for liver lesions. So I'm a big proponent on it. No, everybody is a candidate for it. You need to make sure that the disease is under control and that it's not a large burden of disease because radiation is toxic. And surgery is only good for one tumor and maybe 1 or 2 lymph nodes. And lung surgeries are hard. But I'm a big proponent of doing that. Bianca, remind me of everything. Okay, I'm a big proponent of that because I have a few patients that we have done it and there's no evidence of disease. And first, it makes me very, very aware when they have scans because I'm like Scooby-Doo, just looking for anything because that was treated, right? So you really do that. You also no evidence of disease. My mom right now is no evidence of disease. And I'm talking as a daughter again. She's a different woman now. She went through surgery. So can I tell you how much I believe in that? That my mom went to surgery for her lung cancer for that. And she got radiation to her eye so we can eliminate all signs of disease. She has choroidal mets, so treatment doesn't get there in the choroidal. I put my mom to surgery and radiation. She has been no evidence of disease for a year. She went to the Patagonia, then she went to Cancun. She came to my engagement party. So do I have to say anything? I put my mom through it. I don't know if there's any other proof of how much I believe in that approach.
So
I'm sorry,
it's so
I clear
wonderful
out.
that you believe in it so strongly. Do you have advice for those of us who have medical oncologists that are more hesitant about it?
Get a second opinion. Sorry, have an open discussion. Let me just do the right question. Have an open discussion with your oncologist and show up the data. Because I'm a better doctor every time I learn something from my patients. Little things, little studies. Like I have a patient, I don't say her name, but she's extremely smart. And we were looking for a trial and she found it before I did. And she's doing great. She's in cycle 18 now, that trial. So this is a partnership. This is a partnership. You bring the data, we make the decision because nobody's going to know your cancer better than yourself. At least you're my mom who tries to not know anything. Just like, don't tell me. I don't want to know. I put my mom to a second biopsy because we didn't have enough tissue for RNA sequencing either. And I was like, oh, you are going for a second lung biopsy, dear. For RNA sequencing. Sorry, we have one more question and a bunch of things here. All right, there's one more question, and Leah, I will let you. Oh, sorry. I get so excited. I'm like a kid. Before we go to Terry and Leah takes over, so we have for the first time a Jimmy Fund walking team dedicated to young lung. I opened the team a few weeks ago, and the Jimmy Fund was started in 1948 when Jimmy was a very big Red Sox fan, and then he got cured for leukemia by Dr. Farber when kids were not cured by leukemia. Subsequent to that, in 1989, patients started the Jimmy Fund to collect funds, particularly for cancers that don't get enough research funding. And that's the case for lung cancer. So we started a walking team. Everybody can walk virtually. You can walk with me and my team. You can run. It's 5, 10, 25K, as much as you want. I have been doing it for 3 years with my patients, but now we have our team, which is Young Lung. You're all welcome to join us. The funds for Young Lung, Jimmy Fund, will not go to research. They're going to go to a fund for young patients to support them with Uber rides, stop and shop cars, child care funds. So it's our first year. Welcome all to join us in that call and that walk, and also to bring awareness, because if we have a Young Lung team, people will talk about it. Sorry, Terry, your turn, and then I'm shutting up now.
Thank you for sharing about your mom. I didn't realize that she had lung cancer as well, and surgery. That seems like it was successful. I too had surgery for lung cancer. I'm stage 4. I saw Dr. Cerfolio at NYU Langone, and he removed half of my left lung and my pleural lining. And I was sent home the next day, just walk 45 minutes every day. But I just wondered if there was some protocol now that surgical intervention is being more talked about with the North Star trial and Mara Antonoff, and it seems like it's been successful, and she seems receptive to it too. And I just wonder if there's a protocol for after having surgery that people should know about. I didn't do anything, and it was really difficult for me to recover because I was really worried about, am I going to tear open my lung if I run down the street, or, just in terms of pulmonary and physical therapy, is there something that normally happens, say for stage 3 patients or now stage 4 patients as well?
We don't have a protocol. I am working with Dr. Jeff One, who got a grant, who is developing this technology via Apple Watch that will develop a program for patients to recover. I really hate that patients for surgery, including my mom, and sent home and they're like, peace, because I have recovered for 3 surgeries and I'm in my 30s, and it's awful to recover. The pain, the neuropathy, and women, particularly young women, are at a higher risk for neuropathy than men, particularly because of the weight or breasts. They pull on the muscle. So there is no protocol. I adore Mara. I actually given a talk on her conference. I adore her. I do have to say, all these amazing young women that we care about, your patients, we're just taking over. And we're going to change everything. And Dr. Cecilia Pompley in UK is also developing a program for recovery post-surgically. I agree with you. I think patients are left on their own. That's what I follow my patients after surgery as well. I have neuropathy from my lung surgery for 6 months strong.
Yeah.
And then the gabapentin gives you constipation, makes you sleepy, and then you don't know what is worse, the pain or the gabapentin. It makes you nauseous. And this don't even talk about the opiates. But I do have to say, I found my fiance tends to opiates from my last surgery because I was so bored that I went into a dating app, and then I found my fiance. So it wasn't all bad. Just being real as a human. Otherwise, I don't think I would be engaged. So, all
Yeah,
right.
I didn't know if it was something that it was just missing for me, or if it was more common that patients were released and just kind of sent along their way. And it's been almost a year for me now, and I'm recovered and I feel great. But I do wonder, now that it seems to be more accessible, if that would be a good idea to talk about some protocol. So,
Yeah, so Jeff One's study is promising because he produces everyday follow-up to the Apple Watch, and it produces a program. But it's also very hard to get patients to pulmonary rehab. I was trying to get a patient to pulmonary rehab, and the wait was like 3 weeks. And I thought she's gonna be rehab by the time she can start the rehab. So yes, I agree with you, Terry. I think this is something new that we're doing. And that is robotic doesn't mean it's painless.
right.
To comment directly about this, I actually had robotic surgery in 2019 with Dr. Cerfolio, and I'm still on gabapentin for the nerve pain at the incision site in the ribs. So and it helps, but but I still have nerve pain, even what, more than 5 years out.
Yeah, the nerves really attack you. Talking as a patient, sometimes I don't feel my arm because they had to remove my first rib. And sometimes I'm like, I have an arm. And then you're like, do I take the gabapentin and feel awful, or I just move around and don't have an arm? It's awful. I don't want to make this about me. I just want to empathize with you that it hurts, and it has been 5 years for you, Steve.
Dr. Florez, I really want to just say thank you, thank you, thank
Yeah.
you. This has been amazing. This has been wonderful. It's been nice to see you be so personable and like a real human, not just in your white coat. It's been a breath of fresh air for all of us. I just know it. And for all of you that have tuned in, this has been recorded, so it will be on our website eventually, shortly. And we've also taken all the questions from the comments, and we will make sure to get those in a document. And hopefully Dr. Florez wouldn't mind kind of maybe just looking through them. And if she has any tips or advice, then we can send out just a group email with kind of a summary of the answers of those questions. But I think we could all say a big thank you to Dr. Florez, and I think all of us are leaving here tonight feeling a little bit better about our situation.
Yeah, and I'm gonna be at the ALK Summit in the weekend, so if there's any ALKies, I will see you all guys over there.
Thank you so much.
Thank you.